Okay, well, what I want to talk about is diagnosis of diabetes and making sure that insulin is given to the right patients. And what I'd like to do is to start with something really a bit controversial, with the idea that, in fact, insulin has made it much harder to do diagnosis of diabetes. And the reason I say that is that if we go back into the pre-insulin era, that well, at this time, if you were diagnosed with diabetes when you were young, then as we've heard, it would be an inevitable death sentence and people became extremely ill. And so people who were diagnosed young who didn't die then stood out. And this is the Olsen family. And they developed diabetes in an autosomal dominant way, not only their father, but also of the 6 children, 3 of them developed diabetes between the ages of 23 and 33. And those children, or those young adults who'd had diabetes, continued to work and were fit and healthy. And interestingly, Camage at that time made the comment that dominant inheritance of diabetes was almost invariably associated with a good prognosis. And looking back now, what I think we're seeing is these were the 3% of families that were diagnosed with diabetes where it was monogenic, that it was maturity onset diabetes of the young. And so they stood out because they survived. Of course, as we've heard, insulin came along and everything changed. And so actually, when you go to the the younger generation of the family, so actually the grandchildren of the people we see here, we come across we can now see them in this picture, and this is at a wedding. And again, lots of the family had diabetes. So the bride had been diagnosed at 13, her mother at 17, her grandmother at 23, the bride's mother's cousin had been diagnosed at 12. And although the 2 bridesmaids didn't have diabetes when the photograph was taken, by the time they were 9, they had both developed it. And so we had a family, a dominant history, but the difference now was that as soon as they were diagnosed with diabetes, they went on to insulin because they were slim, they were diagnosed young, and everybody thought they had type 1 diabetes. And what Robert Tattersall did, who was basically rediscovering MODY at this time, was that he spoke with the people with diabetes, and one of them, Mrs. Mason, said, well, of course, I have a holiday from insulin in the winter. I'll have 2 or 3 months off at that time. And so obviously Robert realized that she clearly wasn't insulin dependent. And she said that other members in the family would stop their insulin at particular times as well. And he was able to show that, in fact, this was actually early onset, but non-insulin dependent diabetes inherited in an autosomal dominant way. And so another way of finding someone's doesn't need their insulin, or is not insulin dependent at least, is to see how they do when they have a prolonged insulin holiday. Now, both of these things are a bit drastic. I can't really suggest that you go around to your clinic and start to suggest everybody goes on insulin holidays or stops taking it completely to see who's left standing in your clinic. I think I would rapidly be struck off if I suggested that. What I want to do in my talk today is really talk about how can we find the non-type 1 diabetes that are hidden because they've gone on insulin therapy. I'll try and discuss the mechanisms of finding non-type 1 diabetes, and then really talk about the different challenges. How do we find MODY in these clinics? How do we find type 2 diabetes in type 1 patients? And how do we find neonatal diabetes in our type 1 diabetes patients? And the approaches needed are slightly different in all these cases. So starting off with how do we find non-type 1 diabetes in the clinic? And really, as you'll be aware, C-peptide is an excellent measure of this, co-secreted with insulin. It is a clear marker of endogenous insulin secretion. And my feeling is that really things have changed. When the first research was done on C-peptide, this was a difficult and expensive assay. It's now really cheap, less than 10 euros. It's certainly done in our laboratory routinely twice a week, so it becomes much easier to get. And my feeling is we really should be using this a lot more. I know that in Denmark and in much of Europe, C-peptide is widely measured, but in the UK, it's really been quite a struggle to do it. And one of the reasons is that the labs have felt they're going to have to send it off on dry ice, and that the sample techniques have become very difficult. People suggest you must take it on ice. But actually what I want to show to you is that it's you can use, if you use an EDTA sample, take a blood that's random but non-fasting more than 20 minutes after food, just exclude hypoglycemia, and you can not worry that they're on insulin treatment. And that will be very good at discriminating between the patients with very low insulin who need to be on insulin and those with a higher C-peptide value who actually you could consider coming off it. And just to give you the evidence for this, why do we say use EDTA? Well, you can use a serum gel, and that will be stable at room temperature for up to 6 hours. But the EDTA plasma will remain stable for up to 24 hours, which means it can be done posted, it can be taken by the GP, and that's really transformed our study and use of it clinically. The next question is, what about the timing? And what we've looked here on the left-hand side is after a mixed meal tolerance test. And what you can see is that the C-peptide rises in the first 60 minutes and then is stable from 1 hour after eating the meal. And because of the long half-life, remains stable for at least 3 hours after that. And so what you're able to do is to, is as long as you wait for an hour after meal, it will be at a stimulated level. So the question is, well, how does that stimulation compare if you just do a random value compared to a mixed meal? And this actually plots on the same graph in the same patient when they had a random non-fasting C-peptide done, and then that was compared with a 90-minute blood glucose. And what you can see is they're really well correlated. You actually end up with a very sensitive test. If you're trying to pick up patients who have a C-peptide less than 200, this does it extremely well. It's highly sensitive and specific. And actually the slight variations you see are not clinically important. Whether a level is 1,500 or 1,200 is not important. The only proviso which is shown on this is that the red triangle is the one time when the glucose was 4 or below. So you do want to avoid hypoglycemia. But you don't need to have a particularly high glucose. Another thing that people worried about was insulin therapy, but this was work done by Rachel Besser and Angus Jones, and what they did was to repeat insulin tolerance tests both on and off insulin. Conventionally, the standard insulin tolerance test is done on insulin. And interesting, what we saw was that whilst the glucoses went far less high when the patient was taking their fast-acting insulin, that the C-peptide stimulation was very similar, and actually there's a very good correlation between the two values with and without insulin, suggesting that you really can, you don't need to stop insulin in the patients or worry about that. Okay, so in Exeter, that's really work of Tim McDonald and Angus Jones. They developed the techniques, but actually we gave talks about this, but the person who really took it up was Mark Strachan in Edinburgh. And he went out and said, right, we're going to test the whole clinic. And they set up a system where they tested the nearly 900 patients who were diagnosed as type 1 diabetes, attending a top hospital clinic with type 1 diabetes, and said, what do we find if we measure C-peptide in these ways? And what they found was that 13% had a C-peptide over 200, and actually they then tried to reclassify those with antibodies and genetic tests and other markers. And they ended up with reclassifying around 7% of them as being non-type 1 patients, the majority 5% with type 2, but 1.6% they picked up previously unsuspected monogenic diabetes, usually in the form of MODY. And in about over half of the patients that they reclassified, they were able to either discontinue insulin or adding in oral agents improved control. And they did a mini health economics analysis and said that they'd easily paid for the testing that they'd done. And actually, as years went on, the fact they discontinued insulin become more and more cost effective. So I think really the question is why are we not all measuring the C-peptide at least once in all our patients who are said to be type 1, to give us the opportunity to find these other patients, as well as the value of knowing the C-peptide has on knowing the risk of hypoglycemia and other factors. So there's an advert for C-peptide, if you like. So what I'd like to do now is to move on to talking about finding MODY in amongst the type 1 diabetes patients. And that won't surprise any of you, as you know, I've been working on MODY since 1989, and actually finding them in the type 1 patients are the most important one because it makes the most difference to them. But equally, it is the hardest group to find them in. So how do we do this? Well, what we try and do is to pick them up clinically. We hope that our clinical acumen will recognize that these patients are a bit different from our other type 1s. And often the key clinical feature is the family history. And so Peter, who was thought to have type 1 diabetes, had it for a couple of years. It was really when an astute clinician asked about his family history that everything changed, because when you look there, his dad was thought to have type 1, his paternal grandmother had type 2, his paternal aunt had type 1, his paternal uncle had type 2. But it wasn't a family history of type 1 and type 2, and it was actually a single family of maturity onset diabetes, a young or MODY. And in fact, in this case, we found an HNF1 alpha mutation, and Peter went on to a half a tablet of gliclazide and got excellent glucose control with that. So therefore, we can normally use the clinical features, but the problem is that they're not always as clear cut as Peter. People may not have as many, families may not be as big, they may not know other people in their family, and other things like BMI or HbA1c or age at diagnosis can all help differentiate between MODY and type 1 and type 2, but there are no clear cutoffs. And really, given this situation, it was Bev Shields who really worked out that what we needed was to take the probability of the individual overall, looking at all these different factors and define their overall probability. And that's exactly what she did. And she ended up with a MODY probability calculator, which certainly has now been used over 200,000 times. So people are definitely using it. It's also become an app. And and this has really meant that you can have expertise without being an expert. And I've gone head to head against the MODY probability calculator, and to my shame, I didn't manage to do any better than it. So it is a very good estimation of the probability, although clearly it only uses the things that it uses. So there are other bits that are not in there. So it is just using the clinical features. But the difficulty is that the MODY app you can't use at diagnosis, because you need to say if they go on insulin in the first 6 months. And normally MODY is being diagnosed on average about 5 years after diabetes is diagnosed. And actually we really want to not have people on insulin unnecessary. So the big question is, well, how could you improve this? And the thing Tim McDonald found was that in MODY, the level of antibodies was the same as in the general population. And so therefore there was no increase, which meant it could be used to discriminate. And that really meant that we could use it at diagnosis when C-peptide can't be used because of the honeymoon period. And that led to us working with the the BDD study, the Better Diabetes Diagnosis Study from Sweden. And what they did was to take everybody in Sweden over a 5-year period, 4,000 cases, and they measured the antibodies in an outstanding lab run by Eke Lönnmark and defined with very strict cutoffs positivity and negativity. So the best kind of antibody testing you could do. They found of all pediatric diabetes, this is not just type 1, but all cases were tested, and 12% of them were antibody negative. And then what we went on was to test those people that were antibody negative and those that were antibody positive. And we were able to find that 12% of the antibody negative had MODY, and none of the antibody positive had MODY. And so this meant that there was an overall prevalence of about 1.3%, that we could enrich that tenfold by just studying the antibody negative patients. And that really seems a very rational approach to be using. So the question then is, are you going to test all of those, all 12% of the population who are antibody negative, or are you going to try and be more selective? And if we think about that, what kind of factors might help? Well, one of them is the HbA1c at diagnosis, which is, if you like, a very stressed HbA1c. And actually, you can see this was brilliant at picking out the glucokinase if the HbA1c was below 7.5%. But it did also pick up quite a lot of the HNF1 alphas. It's not, there are patients with antibody positive type 1 diabetes who also have an HbA1c at this level, but it is a good thing to look for when you're trying to look at MODY. Go back to the very first HbA1c that was measured. And in keeping with this, we also found they had less glycemic symptoms. So if we're trying to think about a policy, we can look at the antibodies. The more antibodies you do, the more likely you are to be able to say you get a smaller number of people that are antibody negative. You definitely should do at least IA2 and GAD, because that will mean that it's 18% of the population, or if you do 3 antibodies, it will be 13% of the population. So in England, we've settled for doing 3 antibodies as a kind of compromise, partly because it's also easier than insulin antibodies, which have to be done before insulin therapy. And then with the discriminatory clinical features, we've discussed the low HbA1c. The other one is clearly parental diabetes. And what we've present in the paper from Annalie Carlson and Maggie Shepherd, putting all this data together, was that overall, that if you tested those people who were antibody negative and had either an HbA1c below 7.5% or a parent with diabetes, you'd pick up 96% of the MODY, but you'd only need to test 3% of the patients. So you'd have a 1 in 3 positive. But that has to be balanced against missing cases if you test all the antibody negatives. Okay, so what about, I've started with MODY, but what we said was the most patients that are misdiagnosed are type 2 diabetes in the clinic cohort. And how are we going to pick those patients up? Well, it is quite common, and the interesting thing is this is if you go testing, and it's not just in Edinburgh, that was an Edinburgh issue, it's an issue everywhere. And this was in general practice in Devon around Exeter and also in Leicester. And what we did was to measure C-peptide in patients who were insulin treated. And we compared the C-peptide results about whether they were compatible with a clinical diagnosis of type 1 diabetes, when they should have a low C-peptide, or type 2 diabetes, where they would not be low. And interestingly, we did find overall about 11% of these insulin-treated patients were misclassified. But really, it became very clear that the one group that were most likely to be misclassified were patients diagnosed with type 1 diabetes after the age of 35 who went straight onto insulin. And over 50% of those patients actually had significant C-peptide, suggesting they probably had type 2 diabetes. And so really it's the late onset type 1 diabetes that is very difficult to diagnose and is often incorrectly diagnosed. Of course, there are patients diagnosed over 35 who have no C-peptide at all and have all the other characteristics, but it's where to look if you want to say, where am I most likely to find problems? And you can say, well, why are doctors so hopeless? Surely type 1 is easy to tell from type 2 diabetes. And the main problem that we've got is over the age of 30, less than 4% of diabetes is type 1. And as you get older, you get this kind of tsunami of type 2 diabetes coming in. This is work from Nick Thomas using a genetic definition, which helps get around the problems of clinical classification and needing to antibody test large numbers of people. And what he's able to show here was that really you've got less than 1% will have type 1 diabetes diagnosed between 50 and 60. And so the problem is, how do you pick them up? And how do you tell them from slim type 2 diabetes who may have severe hyperglycemia? And that's why there is often an error. And it is important to pick up these patients because they do end up with DKA, especially when misdiagnosed. Okay, so the next question, well, how can we do this? And what we're seeing is clinical characteristics are difficult, but age of diagnosis and BMI both are good discriminators. The best discriminator, if you're going to go with one thing, is age of diagnosis. Clinicians tend to use BMI. And then the other question is, can we use antibodies? Antibodies do help. And actually the type 1 diabetes genetic risk score developed by Richard Oram and Mike Whedon again is a good discriminator. They're all equally discriminate, as you can see with the error end of the curves. But if you want to do it well, you need to put all these things together. And actually, we're not good at even combining age of diagnosis and BMI, never mind adding in antibodies and type 1 genetic risk score. And it's certainly not something you can do in your head. But if you do, you can see that you reach a point where it is much more successful at predicting likely C-peptide outcome. So Angus Jones has put together a model, and just I think I would recommend it strongly to you. So I'm just going to take you through the different details. There is a paper there which he wrote with his PhD students, but I think that if you go to the Diabetes Genes website, which you can see here, if you then click on the calculator thing, which says what type of diabetes, then you get to this screen. And then you can see here you're offered the MODY calculator or the type 1, type 2 diabetes classification. So you click on the type 1, type 2 diabetes classification. That takes you through to an article discussing this, but also then has a link through there to the beta version of the type 1, type 2 diabetes calculator. And this, you can put in whatever you've got. You don't need to have all of these things, but it takes age at diagnosis, BMI, GAD, IA2, and the centile for the type 1 genetic risk score. And if you put in things like age of diagnosis 34, BMI 28, antibody negative, you end up that's 9% likely that that patient has type 1 diabetes. I think one of the things we have to realize is when are the patients that we should be checking on C-peptide, because there is a chance, in this case about 1 in 10, that they may have type 1 diabetes that will end up as C-peptide negative. So that Angus is still working on this, and there will be improvements, and any feedback you have would be really helpful. But what about antibodies? What about if you can do antibodies on everybody at diagnosis? Then surely that's going to help. And also, surely if you know it's type 1 diabetes and you're a proper diabetes consultant, then you're not going to make many mistakes, are you? And that's been something that I thought myself and many distinguished colleagues have told me over the years. But probably the clearest indicator that it's not true that we really can pick out these patients is if you look at the Address 2 study run by Des Johnson, and this is a UK-wide study where they asked diabetes consultants and specialists to refer in people that they thought had type 1 diabetes as a prospective research cohort. And what they then did was that in Bristol, they measured the 3 autoantibodies on these patients. And the vast majority of them, not surprisingly, were antibody positive, but around 10% were not antibody positive. But the really interesting thing happens when you start to look by age of diagnosis. And this is work done by Nick Thomas and Kash Patel. And what they did was to measure on this cohort the type 1 diabetes genetic risk score. And that allows you to assess within a group how many people have type 1 diabetes. The basic principle is this group here was diagnosed under 18 and had antibody positive. And actually, it looks exactly the same for 1, 2, or 3 antibody positive. This group over here is a cohort of type 2 diabetes, none on insulin, clear type 2. And what you can then see is if we compare these other cohorts, you can say, well, how close are the antibody negatives to the antibody positives? And what you can see is as we get older, and certainly in this group over the age of 30, that the genetic risk score, susceptibility to type 1, has greatly reduced in the people that are antibody negative compared to the antibody positive patients. And it's much closer in the antibody negative to those with type 2 diabetes. And in some elegant maths developed by Nick Thomas and Richard Oram, but what we have been able to show is that we can say, well, actually, if you're antibody negative, what we've got up here is then actually the antibody negatives are almost identical to the antibody positives. And so under the age of 18, even if you're antibody negative, there's a 93% chance that you've got type 1 diabetes. And then if we go between 18 and 30 in this type 1 cohort, you can see then the antibody negative patients start to be less likely to be type 1. And about half of those have a genetic risk score that suggests they're more likely to be type 2 diabetes or non-type 1. And then finally, in those diagnosed over the age of 30, we've got this group here, and the majority of these are likely to have type 2 diabetes based on the genetic risk score. And so what that means is that really, if you're even if an outstanding clinician diagnosed type 1 diabetes and the patient is over the age of 30, that it is most likely that they have type 2 diabetes, and therefore don't be saying, well, it must, because they had ketoacidosis, because they had weight loss, they must be type 1. They deserve to have their C-peptide measured and to see whether it falls. And really at a 3-year one, you should be reconsidering and thinking about that. And this is a paper which is under review at the moment, but I think it will be very important. The other thing it allowed them to do was to look at this thing, well, surely antibodies aren't as helpful in people diagnosed over the age of 30 because they're often negative. Well, one reason that they might be often negative is actually because there is a large number of misdiagnosed type 2s in that group. And so what Cash and Nick Thomas were able to do was to correct for the genetic susceptibility. So you could actually work out of the people who had type 1 diabetes, what percentage were antibody positive. And what you can see here is the result of that analysis. And you can see now in black, we've got the idea of if any are positive, and it's over 90% are positive in all age groups. So in all age groups, if you're more than 90%, and typically it's around 92, 93%, if you measure 3 antibodies, that diagnosis will be positive in your true type 1s. What we can see in the youngest age group is you must definitely measure all 3 antibodies if you're going to get all the positives, because if you just do GAD, you'll only get 65% positive. As you go between 18 and 30, GAD finds you more of them, but you're still missing a significant proportion. When you finally get over the age of 30, GAD gives you almost all of the information about the antibody positives, with the other 2 adding relatively little. And so there is a different pattern of antibody positivity occurring at the different age of diagnosis. And my personal opinion is we should measure all 3 on everybody, because it's very difficult to start changing it depending on the age of diagnosis. But if you are short of money, you could just do GAD antibodies on those diagnosed with potential type 1 over the age of 30. There's a general principle, I think everybody who's an older adult who you think has type 1 deserves antibodies. And then finally, something completely different, neonatal diabetes. And these are patients who may not need insulin despite presenting in DKA and despite having no C-peptide. So this is different from MODY and different from type 2, where there is effectively a misclassification. This is they genuinely did have no insulin, but they don't need it. And these patients typically present with DKA, like Eleanor here, had a glucose of 50, a pH of 7. But though she was insulin dependent and needed insulin at this time, it turned out that she didn't have type 1 diabetes, that she had monogenic neonatal diabetes, and that the vast majority, more than 95% of patients diagnosed before 6 months will have neonatal diabetes, and less than 1% of type 1 are diagnosed before 6 months. So you can use that 6 months as really being a very strong cutoff, and actually it has stood the test of time. We now test monogenic neonatal diabetes up to the age of 9 months, but the vast majority are in that under 6 month group. Why does it matter? Does it matter whether it's called neonatal diabetes or type 1 if they're all insulin treated? Well, they're not all insulin treated, and it was the work by Anna Glein working in Sean Ellard's lab who identified that around 50% of patients with neonatal diabetes had a mutation in the potassium channel that was not closing in the presence of ATP, and that was stopping insulin secretion. And the key thing was that if you add in a sulfonylurea, that channel can open, which gave a possibility that these patients could be treated with sulfonylureas. And what we now know is indeed they can be treated with sulfonylureas, and it's not just that they can avoid insulin, but they get better glucose control. Their HbA1c improved in every single case. You can see on the traces there that the glucose, having been high and erratic, becomes low and stable. And these patients, it made a dramatic change to their life. They suddenly could do sleepovers, they could go on trips abroad, they could play football at school, things that they'd been avoiding because the teachers were concerned about it, and suddenly their life was dramatically changed. And people were concerned that these patients, that there would be sulfonylurea failure, and Pam, working with colleagues from Norway and Italy and France, have done a follow-up, and what we've been able to show is that the HbA1c remains superbly well controlled, and the glyburide, the insulin dose, which is got normally glibenclamide or glyburide as they call it in America, has actually been, if anything, slightly lower in milligrams per kilogram. So there's no evidence of sulfonylurea failure. Another thing people were concerned about was hypoglycemia. There are some hypoglycemia, but they are far, far less than insulin. And these patients have had 750 years overall of follow-up, and there have been no hypos with loss of consciousness or seizures in that period. Well, most patients had it when they were on insulin. So it's a good, successful therapy, and that makes a big difference. But still, there can be a problem. And one of the tragedies can be that we find a patient has one of these mutations, but they already have severe neurological features. And those severe neurological features have occurred not because of the mutation, but because they had coning and cerebral edema when they presented in ketoacidosis. And it's not surprising if you present at 6 weeks with a blood glucose of 70 and a pH of 6.9, trying to manage the fluid balance is incredibly difficult on a tiny baby who may only weigh 4 kilograms. So it's extremely difficult to manage, a very dangerous time. And most parents say we were told there was a 50% chance they would live through the night. And so what is happening is there are individuals who end up with long-term disability, and these were 2 families that we reported. In both cases, there was a family member who presented with DKA who ended up with spastic tetraplegia, and another family who presented with more routine tests, and as a result of that, they had a completely normal neurological outcome. And so it really shows if you could stop ketoacidosis, as we're trying to do in type 1 diabetes, in neonatal diabetes, it could really make a big difference. And this is work that Tim McDonald has been working on, and some really elegant studies. We obtained the blood glucose, the glucose spots, the five-day TSH screening that's done routinely. And Tim was able to extract the glucose from those, compare it with control values, and show that even at 5 days in neonatal diabetes, the glucose was raised. And he published that data showing this clear discrimination. He's gone on to develop glucose testing that can be done within the present metabolic screening that is going on. And that means you can do it extremely cheaply. To adding glucose becomes a matter of a few cents. And it then would become, if we're going to detect 1 in 100,000 births with neonatal diabetes, then that really would be, and the saving that would come from presenting both death and long-term ill health would be considerable. And so at the moment, Tim is doing studies where he's trying to test the really putting this into practice in Plymouth and some other places in the south, Portsmouth and other places in the southwest, with the idea that he will be able to see with the control data what the false positive rate is, because that will determine its utility. So, in conclusion, there are patients on insulin therapy who don't need it, and the wonderful discovery of insulin has meant they're a bit harder to find. The best way to find them is a random non-fasting C-peptide, but it is late, and that because of the honeymoon period, you're really going to find them 3 to 5 years after diagnosis. So think about trying to pick them up earlier by questioning it in those when they're antibody negative. And really what I've tried to show is I think the best way to prevent or diagnose MODY and type 2 diabetes patient is to pick up these patients early. And I think to try and use either clinical probability models rather than thinking that we can do it all ourselves, to try and use that, but also to then develop systematic screens that pick up everybody. And what I would say is I think that everybody going on insulin deserves 3 antibodies to be measured. And when they're negative, they deserve a C-peptide. And on that, I will leave you. It just leaves me to thank the colleagues. This work has really been done by an amazing set of up-and-coming stars in Angus Jones, Tim McDonald, Kash Patel, Nick Thomas, and Richard Oram. They're really innovative thinkers, and they spark off each other. And it's a real privilege to see their work develop as it is and to be able to present it to you today. Thank you very much. Be happy to take any questions.
We have time for a few questions. Now you can see the audience. And the first question is from Elisabeth Mathisen, sitting up there.
I'm here.
Can you hear Elisabeth?
Yes, I can. Thank you.
Great. I'm working with women with gestational diabetes, but also women with diabetes and men with diabetes in general. I have also always wondered if a person with type 1 diabetes does not have antibodies, a few of them have MODY and some of them have type 2 diabetes, but what do you think of the rest of them? And the other thing I always wondered is that you must have a certain positivity in the background, at least for GAL antibodies. So some of the background population must be positive despite not having diabetes. How do you cope with that?
Yeah, it's a very important question. And I think what an antibody means depends completely on the clinical situation in which you're measuring it. So what I was talking about was the prior probability being high because the doctors have thought it is type 1 diabetes. And that's one situation where measuring antibodies can be interpreted in the way that I talked about. If you do another thing and you measure antibodies on everybody in your clinic with no clinical suspicion, then the prior likelihood, the vast majority will be type 2 diabetes in the population, and therefore many of those antibodies would be the same as you would find in a non-diabetic population and not have the same significance. So the impact of the antibodies depends on the setting in which you are looking at it. And actually, if you use Angus's model, that actually comes out. So when you put in an age of diagnosis of 50 and a high BMI, and then you put a positive GAD, it still tells you it's most likely to be type 2 diabetes and not type 1. So I think you've got this thing of the test being different according to the prior probability. And it is one of the things that it's taken me a while to get my head around. But now I think it's one of the things that we make the most errors with when we try and think a test has a sensitivity and specificity more generally. And it does depend on the clinical setting.
Yes, there's a question there.
Hello, can you hear me now? My name is Ole Svendsen. I'm from Bispebjerg Hospital. And regarding the cutoff levels of the C-peptide, you said 200 picomolars was then it was type 1 diabetes, and about 600 picomolars it was type 2 diabetes. But is that at time of diagnosis? Is it after 5 years? Is it after 20 years of having diabetes? Because the C-peptide levels, I guess, falls when you have had type 2 diabetes for, let's say, 20 years. And what do we do in the gray area when you want to predict whether it's, or say whether it's type 1 or type 2 diabetes? The area between 200 and 600 picomolars.
Yeah, so I think, again, as clinicians, we've got used to the idea that a test gives us an answer and that we can cut it off with values. And I think that's partly deliberate with the 200 and the 600 in our review, is that there's an awful lot of patients where we can't be certain. And therefore, that's when you need to keep thinking and keep doing other tests. And even when it's over 600, of course, that could be the honeymoon period. So it's really saying there's areas of uncertainty. And obviously, a value of 20 is very different from a value of 199. So I think it's trying not to, and the other problem is the C-peptides tests vary between labs. So I think it's trying to give some idea, because one of the problems was C-peptide values were fed back to us with no guidance. So the review article that Angus wrote tries to give those guidelines, but there is an area in the middle where we don't know, and you just keep measuring it and seeing what happens and keep an open mind.
Okay, thanks. And another question here.
Simone Sneppen from Copenhagen. Some 10, 15 years ago at the Danish Endocrine Society meeting, there was an English guy who came and gave an overview lecture. His name was Professor Gale. It was very, very interesting, and it was about sort of the oscillations in fashion between, strongly distinguishing between type 1 and type 2, and how sometimes the two diseases tended to merge in phenotype, and sometimes they tended to diverge in phenotype. And I've been listening closely to hear if anybody would say type 1.5, but it seems to have gone quite out of fashion. Do you have any comments about this?
Okay, so it's quite difficult to hear, but I think you're talking about type 1.5, and are the people that lie intermediate in these categories.
Exactly.
Personally, I think the thing that matters about whether you need insulin or the extent to which non-insulin therapies will help a patient depends on the C-peptide. And so therefore, and if they do have a progressive disorder of the pancreas that's going to result in increasing insulin deficiency, over time that will declare itself. And actually they will move to being insulin dependent. They may be insulin dependent and obese, but they're still insulin dependent. And so I don't find the classification of type 1.5 very helpful. There are people who may initially not be diagnosed with type 1 and then get it finally diagnosed 3 years later. But often I think they have a similar course to those who were diagnosed at diagnosis of diabetes. And so I personally am not in favor and haven't, if it helps practically, if there are practical differences that you make, then that's good. But I would say that for most situations, it's the C-peptide that tells you whether or not to use other therapies other than insulin, and whether you need to continue with insulin. And so that's why I think we should be more C-peptide based rather than things like BMI.
So Edwin has a question coming.
Oh dear.
Hi, Andrew. We really miss you here, but it's lovely to see you. I hope all is well. I was just quoted by the last questioner as having 20 years ago expressed an opinion, and it's very nice of her to remember me expressing an opinion. I think someone who can measure things is always going to be someone who has an opinion. But I will say that the thing I really strongly endorse in what you say is the uncertainty principle. There is an awful amount of circular reasoning in saying that someone with antibodies has type 1 diabetes and that someone without antibodies has type 2. You start off where you finish. It's like some of the early LADA discussions when anyone with GARDA was regarded as having LADA. And of course, since 5% of the normal population at that age group had GARDA, you're going to make 5% of people with type 2 diabetes in that category anyway. So all I would say is any move towards measuring things is much better than not measuring things. And that what I really liked in your presentation was the fact you've got to keep your mind open to stop your brain falling out. And you've really got to treat people as individuals. So congratulations on that. Wish you were here.
Yeah, I wish I was there because it would be able to correct that misconception that I think antibodies means that it is type 1 diabetes. I think I'd really turn it around the other way. If you clinically think it's type 1 diabetes and you measure the antibodies and they are negative, you should rethink. And I think that's really the point I'm trying to make. Not that there is a right or a negative, or that type 1 diabetes is defined by antibodies. And indeed, it's clear that 90% of children under 18 who definitely have type 1 diabetes are not the ones that are antibody negative. They still have type 1 diabetes. So you can't use it in that way. But it's just, when do you think and when should you be thinking about it? Because you can't be thinking the whole time. You have to get on and treat people. So I think it is about prior probability. And that's what you were saying there, Edwin, when you did the thing about LADA. And you will have seen that Angus Jones and myself have really put what we've tried to is why we don't believe, we think it's all to do with prior probability. And actually, that's why you need to interpret any test in that setting. And that came out in Diabetes Care just a month or two ago. And I think it is a danger when we do classify a disease. And I've always been with you on the LADA argument. I guess I'm trying to help clinicians in a practical way of saying, when can you relax a bit and you don't need to be testing for MODY? If you turn it the other way, what we found when we're looking for MODY is that antibodies in a young patient diagnosed under the age of 30 is not associated with us finding monogenic diabetes, and that allows you to save a large amount of money by not screening those people. It doesn't say it's impossible, but it says it's extremely unlikely, and if you want to save money and not have negative tests, it's a good way of doing it. And I think that's often what we're about. What Angus Jones is doing is developing things against a C-peptide outcome at 3 years, which in the end is what matters in terms of therapy. And I think that prospective study that he's doing will be very important.
So 2 very quick questions and very quick answers. Henrik?
It's a short question, yes. Well, I noticed that you actually recommended to screen for neonatal diabetes from 6 to 9 months, actually. How many more will you find if you increase the time span there, actually?
So, sorry, if you increase it from 6 to 9 or above 9?
No, well, you recommended it from 6 to 9 months, actually. So is it worth doing it that? Because it's difficult, actually, to measure the mutation in the potassium channel. Yeah,
so under 6 months, the positive rate for finding monogenic diabetes is around 82%. And getting higher all the time as we find new types. Once you get over between 6 and 9 months, that falls to about 2 or 3%. in some studies 5 or 6. So what that means is that, and then it does, if you've got somebody who's going to have a lifetime of diabetes, then even a 2 or 3% chance is worth finding. If you found a potassium channel, it would change their therapy. Most of the later onset neonatal diabetes genes after 6 months tends not to be potassium channel. So it doesn't normally alter therapy.
So final question, I will take the liberty to address it myself. So Andrew, with the decreasing sequencing prices, soon it is very, very cheap. Should we sequence everybody and then use the other clinical information to interpret the variants we find?
Yeah, I think we'll love to discuss it with you over dinner, Torben, but we can't. So I just say that I would love to do that. And I think when it gets cheap, although we still have to be careful because of interpreting, as long as we just go with very definite variants, because as soon as you start looking at uncertain variants in uncertain clinical diagnosis, that's when a lot of harm can be done or misdiagnosis can occur. So I think that's the only problem with having even more information. But I do think that if you can limit it, if you just report the clear positives, then I would love to be able to afford to take everybody who's antibody negative and sequence them.
Okay, thanks a lot. Let's give Andrew a hand more.